just have these few topics. I'll look at the principles of psychological management, psychological formulation of the condition, and then also look at the psychological management. Now, the principles of psychological management. I did something that always undergo. You're traveling to work in the morning, or you're traveling somewhere for church service on a Sunday, and you get into a jam. And it's not moving, and you're like, whenever the policeman here, there's jam. When there's no police, there's no jam. And you're very annoyed. But most cases we tend to say that we're annoyed or we're angry because of the jam. And that is where we tend to get things wrong. And that's what psychological management is all about. We want to look at the interplay between our thoughts, our emotions, the behavior we display, and even the physical sensations. There's a way they play out together. So it must have something like a trigger. In the example I showed you before, the trigger might be the traffic jam. The traffic jam won't lead you to getting angry. There's another path it takes. We always interpret an event. Whatever happens, we put a thought component to it. So what from the traffic jam, what does it mean? The thought will be, I'm going to be late for the exam. I'm going to be late for the interview. That brings about the emotions. You get angry. The physical sensations, heartbeat increases, you begin sweating, you begin panting, and you begin hooting like a madman. And all these things, keep on playing out in that particular state. And sometimes you can find them, interacting together. The emotions lead to the behavior, the cognitions lead to the physical sensations. But it all comes down to what happens in the thought process, the appraisal. And this, in a nutshell, is how I can explain CBT or psychological management. This slide itself, it's an overview of how we manage patients. We have to understand what is the thought component when they encounter these situations. How do they think about the symptoms? So, you're not angry because of the jam. You're angry because you think you're going to be late for the meeting. And that's how we help the patients to look at their situation differently. So CBT is an evidence-based treatment. It's called cognitive behavioral therapy. It identifies and changes negative thinking, as well as the accompanying maladaptive behavior. We also look at some of the maintaining, what we call perpetuating factors. What maintains this condition? What maintains the patient keeps the patient doing the same thing all the time? In many cases, like we're going to see, we tend to use something called exposure to the problem or the feared sensations. I will normally do it as a take-home assignment. We work with the patient, get tasks, and ask them to go and do those things, and we come back and see how that changes their thinking. So, the next thing we'll talk about is the psychological formulation of psychosomatic disorders. Now, in the DSM-5, they say it's not about the somatic symptoms that really matter, but instead the way they present and the way the patient interprets them. So you're going to have patients who might have the same symptoms. It doesn't matter. What matters is how does this patient interpret them. So the focus is not only about the somatic symptoms, the pain, the difficulty in breathing, the blackouts, but how are these perceived? So incorporating affective, cognitive, and behavioral components into the criteria for psychosomatic disorder provides a more comprehensive and accurate reflection of the true clinical picture than can be achieved by assessing the psychosomatic complaints, the somatic complaints alone. So somatic disorders result from failure to manage stress, other things that are bothering patients, and these manifest in complaints. So here is just a template you would want to think about when you're looking at these patients. What are the triggers? When do these things normally happen? When these things happen, what does the patient think? What goes through your mind when you begin feeling dizziness? For some patients who came with dizziness, how do you feel afterwards? And again, you have to understand these terms, emotions. People tend to confuse emotions with thoughts. Emotions are things like anger, fear, apprehension. That is an emotional state. So we want this to come out quite clearly. And then what were the physical sensations? When you felt the fear, what changes did you feel happening in your body? What changes were you feeling in your stomach? You know, to try and get out some of these things they tend to feel. And then the behavior. What did you do when you felt these things? And all these things actually have a role in some of these conditions. The thoughts are what help the patient, the thoughts are the way the patient views the problem. And these differ from patient to patient, but also give an idea of what is the patient going through. In mental health, we try to be empathic, to put ourselves into the patient's shoes, to be able to help them better. So by knowing what they were thinking, how they were feeling about something is quite important. Then the feelings, the emotions. Many patients come here because of the emotional state. They are sad, they are angry, they are guilty, and so on. We need to also understand those. The behaviors are equally important. Some of these patients who have the feelings of dizziness, difficulty breathing, like we've talked here, they'll say, at school when that happens, I run to the nurse. You see? Why do they run? Dr. Mpami mentioned something, catastrophe. They think something bad is going to happen. So they run to the nurse to prevent the bad thing from happening. And then they will say, well, the nurse saved the day. I did collapse, I didn't faint. But these behaviors actually maintain the problem because they get to learn that actually there was probably nothing that was going to happen. But because they keep on running to the nurse, then these behaviors are maintained. And in the physical sensations, again, because of the physical sensation, this again feedback into the cycle, and it kind of maintains it. And this can give an idea of why do some of these patients get the blackouts. When a patient starts feeling that there is something wrong happening to them, something bad is happening to me, and they get scared, and then they have these physical sensations, it's actually more evidence now that, now the heartbeat is increasing. Now I can't breathe, I'm choking. Seems trouble is happening. And that's an alarm to the brain, which again heightens the fear. That's why sometimes you'll hear them saying that, it keeps on increasing, and some of them get overwhelmed, blackout. So this is how you tend to see patients tending to collapse, because the situation goes beyond what they think they can manage, and they say they black out. So in many cases, it's also difficult to actually get what the patient's thoughts were. So the patients might say, I don't remember sometimes what happens, So you want to ask them to probably take something home, and then they can record some of these things. We had a young girl we saw last week, I think. So they are going to buy French diary, so that they can be able to, she can be able to write down what thoughts happen when she's in a class, and then she feels that the dizziness is coming, the headaches are coming, and the blackouts. So after those episodes, can she be able to record and say, I first felt this, I thought this was happening, and so that by the time they come back, they have a thought record for at least 4 or 5 days. Now in psychological management, the pathology is the thought. So similarly, as you go and they talk about UTIs, you go to the lab, take a sample, you're looking for the pathology there. We don't have any other means of getting to the patient's brain to know what's happening. It's only them who can tell us what the record is. And sometimes when they come to the clinic, they can't actually remember, doctor, I can't remember what exactly happened, what I was thinking at that time. So you actually want to see how they can be able to record these things immediately after they encounter these things. So here we have activity. Activity means what were they doing. So it could be I was in a class sitting, the teacher was given an assignment, or we were going to an exam, and then I thought, I haven't prepared, I'm going to fail. Then I got scared, and then we also want to look at the emotion. We want them to rate emotion on a scale of 0 to 10. So if you were angry or scared, how strong was it? 8 being like very high, 9 being extremely, or 1 being low. Again, this helps us later on in therapy. I put these columns here, alternative thoughts. Now, these two columns come after we have now trained them how to critically evaluate this negative thought. And then if they can now substitute it with an alternative thought, what is the resulting emotional state? And you already see that normally the emotional state here is more positive. The emotional state here is more positive than in the first instance, after they have gone through the practice. So that was just to give us to take you through how we formulate. To formulate, we have to keep on doing a number of investigations. And Dr. Mwesuga said that sometimes after one session, you're still asking yourself, is this a panic attacks? Are we looking at somatization? Are we looking at conversion disorder? You still have those different hypotheses. Now, the management. The management which I'm going to discuss is actually based on what we have experienced on the ward, and it's quite interesting that the cases here were teenage girls, and that's what I've almost always seen. Most of the patients who come with these things are always young girls, and I've never known why it is really. But I think there are a number of challenges they face around that stage. So the treatment of choice is exposure therapy. And this is mainly for situations where the patient presents with anxiety. And I think most of the two cases we had here, there was something about anxiety. The dizziness, then they have the headaches, they feel like they can't breathe, they are choking, and then they have these blackouts. So in exposure therapy, for panic, which is one of the symptoms we tend to see in some of these conditions, we tend to do what they call interoceptive exposure. You expose the patient to their feared sensations. Now, patients who have some of these conditions, they are so keen to pick out a change in the normal bodily functions. Say, suddenly I feel my heart is pumping so heavily. Well, that is normal. Sometimes something happens and you start feeling increased heartbeat, or you feel a choking sensation. There are patients who I've seen who would get in school, who would get these attacks when they are doing general cleaning. Because when they are doing general cleaning, there's so much dust, then they are choking and like, So they tend to call them asthmatic, and then they're exempted from doing general cleaning because they have asthma. But it's actually somatization. So we expose them to some of these feared sensations. There have been patients whose one of the feared sensations are things like when they feel tensing of like shortness of breath. Then you can have them in therapy, they jog for about half an hour, and then they start feeling that they punch and they say, oh, it's coming back, So the therapy exposes them to some of these sensations. But it goes hand in hand with what we call cognitive structuring. After identifying these thoughts, the negative thoughts, we then have to look at the evidence for those thoughts. What is their benefit? Is there another way they can look at the situation? That's what we call cognitive structuring. And also identifying some of the maintaining behaviors. Can this also be dropped? So this, in a nutshell, is what we call the exposure therapy. But the other issues that happen in these patients, some of them, it might be issues at home, challenges with the family, challenges at school, how they deal with their peers. So other treatments are also recommended. Problem-solving training. Can we help them to deal with how to manage problems, how to think critically about an issue and deal with it? Psychodynamic therapy, really trying to get down to what are some of the things that might have happened in the past that might be contributing to some of these conditions. Some actually mentioned about trauma. Yes, trauma is indicated in a number of these somatic complaints because previous traumatic events can trigger some of these conditions, somatization disorders, dissociative disorders, and so on. Then also interpersonal therapy. Are they having challenges with dealing with other people in the society? Again, this helps them to deal with some of these problems that they encounter. So, in summary, Psychosomatic disorders are a manifestation of psychological stress. And what we do here is that we identify what are the pathways, the cognitive pathways that bring about this condition, and then we target those pathways using a number of treatment techniques. Thank you.